My Doctor, your health anytime, anywhere. Hello, lovely people. My name is Mwesigwa Joy, and this is the My Doctor podcast, where we basically discuss different health issues. What are their causes? How can we prevent them? What are the solutions? When should you seek for help? Different things. We have very many episodes, so if you haven't watched them, you can just search My Doctor podcast on our YouTube channel, and you'll find them there. So for today, we have an interesting topic. We're going to be talking about antimicrobial resistance. What is antimicrobial resistance? Have you ever noticed that maybe when you were younger and you would have like a cough and you take amoxicillin and it gets better, and now it does not get better, you don't get cured? Is that antimicrobial resistance? We're going to find out in this episode. So I have a guest with me. His name is Dr. Simon, and he's going to introduce himself. You're welcome, Dr. Simon.
Like you've rightly said, I'm Dr. Simon Sekyanzi, and I'm a medical microbiologist. I'm a specialist medical microbiologist. I'm also a lecturer of microbiology.
Thank you so much. So before we dig into the topic, I'd like to inform you that this episode is a collaboration with the UCU Antimicrobial Resistance Club. Yeah, and so let's dig into the topic. So for Dr. Simon, before we talk about antimicrobial resistance, I'm requesting that you tell our viewers what antimicrobials are in the first place. What are they, for a layman to understand what we are talking about?
So antimicrobials are basically compounds, chemical compounds that are used to treat or to kill, to treat infections that are caused by microorganisms. And microorganisms are many, quite in number. So you have bacteria, you have viruses, you have fungi, you have parasites. So anything that can kill those particular microorganisms is called an antimicrobial. Though usually people use antibiotics to refer to all antimicrobials. Sorry, to basically antibacterials, the ones that deal with bacteria, the ones that kill bacteria. Yeah, but antibiotics, antimicrobials basically means the same thing. You're having these chemical compounds that will deal with these microorganisms or with these life forms that cause infections. So those are
Okay. So what is antimicrobial resistance?
So then antimicrobial resistance becomes a phenomenon where the antimicrobials that were previously effective against those particular antimicrobials that I've mentioned, previously effective, all of a sudden become ineffective. Okay, they were previously efficacious to treat given infections that are caused by those particular antimicrobials, and later they become ineffective, basically.
So in simple terms, it's like I used to use this medicine to treat this disease, but now it can no longer help me to treat it. Okay. So what are some of the causes for such cases?
Antimicrobial resistance basically arises because of what we call antimicrobial resistance determinants, which are actually genes that are possessed by these organisms, by these microbial pathogens. So these genes can be acquired in many ways. Okay, they can be natural, okay, or they can be possessed in many ways. Can be natural, naturally occurring genes within the bacteria, or they can be acquired by the bacteria. Okay, and once these bacteria acquire them, okay, then they can spread in many ways. They can spread vertically between bacteria of, for example, from mother to child, okay, or they can spread between bacteria that are unrelated, okay, what we call horizontal gene transfer, okay, and these resistance genes can occur because of mutations, okay, when the genetic makeup of these bacteria change, okay, or they can occur because the bacteria has actually acquired these particular genes from another bacteria, what we call horizontal gene transfer. And once this happens, bacteria, then these genes can actually be able to produce, for example, say enzymes that can break down these antimicrobials. We have examples like beta-lactamases that break down beta-lactam antibiotics. That's a class of antibiotics. We have your penicillins, where you have amoxicillin, natural penicillins, like PenV, PenG, ampicillins, okay? Cephalosporins like ceftriaxone and many others. Those are beta-lactams, okay? So those are broken down by those enzymes. But those genes can also alter the targets for those particular antimicrobials. For example, you have penicillin binding proteins, which are the targets for the beta-lactams. Those ones can be altered so that you have a mutation in them, and that gives rise to antimicrobial resistance, because the antibiotic cannot bind to its target because it has been changed. For example, MRSA arises like that, methicillin resistant Staph aureus. And then you have altered transport, okay, of the drug into the bacteria, because the drug has to enter. So bacteria enter through certain, should I say, paths. For example, porins, those are protein parts where antibiotics are supposed to enter the bacteria. Those ones can be altered so that now the bacteria cannot get in. Or if the bacteria gets in, it can be pumped. So if the antibiotic gets in, it can be pumped out. Or that is altered transport, and that can,
Okay, so are there things that we do as people, as we're taking the antibiotics, antimicrobials, are there things that we are doing that are causing that to happen? Or it just happens? Like, are there some things we are doing, like maybe underdosing?
Of course. So basically what I want the viewers to understand is that resistance does not develop at that moment when you misuse the drug. Okay, these genes that I've talked about that cause this resistance are already there in the environment, in the bacteria. The bacteria have them. Okay, and what we do, okay, so some bacteria have them, others don't have. So what we do when we take antibiotics is that the antibiotics select for the bacteria that have those resistance genes, okay, and they survive. And the ones that do not have are killed. So that the ones that survive, that are resistant, that have the resistance genes, now produce and multiply and become the predominant bacteria in the environment. Okay, so that the chances of you getting an infection that is due to a resistant bug are high, vis-a-vis what was there previously when they were low in number, and therefore the chances of you having a resistant infection were low. Yes.
You talked about drug misuse.
So basically what we do is to escalate. Okay. So the practice we do is simply escalate the emergency of these resistance bugs, the selection of these resistance bugs. For example, when we misuse the drugs, for example, underdosing, okay, or using the drugs for infections that are not supposed to be used for those particular drugs. For example, if you have a viral infection, you have a flu, and then you start using azithromycin and others. Okay, azithromycin is an antibacterial, but you have a flu which is viral. Okay, so you miss you using the antibiotic inappropriately. Okay, and then if you decide probably to just treat without finding out, without using the diagnostics to find out whether you're dealing with a bacterial infection or not, you just prescribe anyhow, empirically, because probably you think it's going to take long for you to get the results, or it's going to waste a lot of money, other things. That can also escalate. If you are in agriculture and you're using these antibiotics too, not to treat the infections, but to promote growth of your animals, or to just to do prophylaxis. You anticipate an infection and then you give an antibiotic. Infection is not yet there, but you're just anticipating, and then you give. That all escalates the emergence of AMR. The physician, when they are prescribing, fear to lose clients because the clients are demanding for antibiotics. They're saying, you know what, for me it is amoxicillin that works for me. Even when I have this flu, when I take this amoxicillin, it works. The physician, instead of educating the patient, they fear to lose the patient, so they give the antibiotic. Okay? And many other practices that we do.
Okay. I read somewhere, and they're talking about how antimicrobial resistance can be spread from animals to humans. Like if I eat maybe meat of a cow that has been exposed to many antibiotics, like you talked about, just to make it fat or something, that the resistance could be spread to the human. Is that true?
That is very true. For example, the meat, when you give these animals antibiotics, definitely some of those antibiotics will enter the tissues, the meat, and then when you eat, we expose ourselves to those antibiotics. Remember, these antibiotics are at what we call sub-therapeutic levels. They are not the right doses, okay? And when bacteria are exposed, or when microorganisms are exposed to those low doses in the meat, okay, they become what we call sensitized to those doses, and then somehow, uh, you know, because of course those doses are not going to kill them, but they're going to induce mutations, okay, that are going to now lead to resistance to those antibiotics when they are now used rightly later, when you get an infection due to that particular antibiotic. So when you get that particular infection. So in other words, what we are saying is that we have organisms that live in our bodies, in our GIT, in our skin. Okay, when we take these meats that have those low doses, these bacteria that live on our bodies or in our bodies will get sensitized to those antibiotics, and they're going to now develop resistance to them. Okay, now when those bacteria now interact with the real disease causing pathogens, when we are attacked, they are going to pass on these resistance genes to them. Okay, because the bacteria interact, they're not like us. We cannot, for example, I cannot pass on a gene to you. Okay, it's your mother or your father that's supposed to do that. But for the bacteria, it doesn't matter. Okay, unrelated bacteria can interact and acquire genes from each other, what we call horizontal gene transfer. So that's what happens when the real bug comes and interacts with these bacteria that are supposed to be residents in our body that acquire this resistance. They're going to pass on these genes to them, and then they will be resistant.
That's interesting. Okay, so how does someone know that they actually have antimicrobial resistance? Are there any tests in place? Any diagnostic tests? Yeah.
Yeah, sure. So basically, when you get an infection, a sample is supposed to be taken from you. Of course, a diagnosis is supposed to be made. You're supposed to go to the doctor. Diagnosis is made, established clinically, and the sample is taken off. That sample is taken to the lab, which runs it, okay, and then is able to determine which organism is there, and also runs what we call susceptibility testing, meaning runs a number of antibiotic panels against that organism to see which antibiotics it responds to and which ones it's resistant to. So that is how you can be able to detect resistance. But at a clinical, that's now lab level, but at the clinical level, when the patient comes, you make the diagnosis, you start them on antibiotics. Ideally, you're supposed to start them on antibiotics after taking off the sample. Okay, as you wait, or if you do not take off a sample and you just start them on what we call empirical treatment, if that treatment fails to work, so if there's treatment failure, if the treatment fails to work, then you can suspect that there could be resistance to this antibiotic. That is if you've given the right dose, okay, the right frequency, the right duration, and you're sure that there was actually an infection there, because it could be something else.
Something else. Yes. So after we have established this person has antimicrobial resistance, what next? Are there any measures or any treatment measures? How can this person be helped?
It depends on the level of resistance, because there are several levels. You can have what we call just antimicrobial resistance, maybe when you're resistant to just one class, okay? maybe you're resistant to the beta-lactams, so that the quinolones and others, aminoglycosides can work. Okay? So all we need to do is to have that susceptibility profile or report from the lab, and then we see which antibiotic you're sensitive to, the drug, the bug is sensitive to, and then we give. If it's MDR, that means you're resistant to 3 or more classes of antibiotics. That means the treatment options are becoming reduced, becoming limited. So definitely you need a report to see what other classes still work. That is for MDR. Extremely drug resistance, when you only like 1 or 2 classes can work. Okay, so still we shall choose from those 1 or 2 classes. Pan-drug resistance is when there is resistance to all antibiotics. No antibiotic can work. So there's nothing to choose from. There are no treatment options left. Okay? So
For pan, what do we do?
it's palliation basically.
Palliation, eh?
Palliation, emotional support, mental health support, basically. Okay? And of course, it depends on the level of the lab, the level of testing. Of course, some labs, for example, when we talk about pan-drug resistance, we are talking about resistance up to colistin, when colistin cannot work. Okay? In that case, for example, in a resource-limited setting like ours here in Uganda, such a patient, and if the patient is poor, such a patient now will be undergoing palliation and other measures. There's nothing you can do. But in other high-end countries, there are options, okay? But they're very expensive. They're not available here. When colistin fails to work, you can resort to things like ceftriaxone, tazobactam, okay? All right? Which is used to treat carbapenem-resistant organisms, carbapenem being the last line antibiotic usually in our settings. You can use antibiotics like meropenem, verbobactam. Okay, so those are combinations. Okay, you're combining a beta-lactam with what we call a beta-lactamase inhibitor. Okay, a newer beta-lactamase inhibitor. Those are newer beta-lactamase inhibitors. Verbobactam, relebactam. You can combine imipenem with relebactam. So those are the newer drugs. What we call the novel beta-lactamase inhibitor combinations, which are not available in our settings. Okay, very expensive. You have to probably order for such drugs, and if the patient is very poor, they cannot afford. It's only maybe people who are rich, politicians and all that can afford such, measures.
Okay. So I'm sure our viewers, we don't want to reach that stage. So how do we prevent as normal people, what measures can we take as people to prevent antimicrobial resistance?
That's a very good question. Prevention is very key. So, in other words, what I always tell people is that we cannot win the war, okay, of AMR with the microbes, okay? Because the microbes, what people do not understand is that these antibiotics that we are using to kill these microbes, the microbes used them before even many life forms had not existed on the earth, okay? So, and they were using them to fight amongst each other as microbes. So that's why when you look at all those antibiotics, they're actually coming from organisms. Most of them are coming from certain bacteria, from certain microorganisms. Most of the antibiotics are coming from fungi, they're coming from streptomyces, or that's a bacteria, okay, bacillus species, okay, and many others. So these bacteria were producing these antibiotics to fight themselves, okay? And so these bacteria know these antibiotics better than we do. Because when did we start using antibiotics? We started using antibiotics in the 1940s, 1945, Second World War, okay? That is just, if you count from Second World War up to now, that's like 80 years. We've just used antibiotics for 80 years as humans. But bacteria have used them before us for billions and it's estimated 2.5 billion years have been, producing these antibiotics and using them to fight against each other. So we cannot win such a war where we are out-experienced by these bacteria because they have been using these molecules for far too long. We are outnumbered We are out. So what we need to do is to de-escalate. The practices that we are doing that escalate the emergence of AMR, we simply need to sit down and de-escalate that. Okay? So we should ensure that we use antibiotics prudently. Okay? Prudently, I mean use them only when you need to use them. When you're sure you're dealing with an infection, an infectious disease. Okay, that's one. When you're using them, use them in the right doses, okay, the right frequency, and in the right duration. That's what we call antimicrobial stewardship. Okay, that's one. Second, infection prevention and control. So we need to ensure that first of all, because what I tell people is that AMR, even when you're using antibiotics well, AMR will develop because AMR arises from the use of antibiotics, the selection pressure. The moment we use antibiotics, we expose these bacteria to, or these microorganisms to, that pressure, and they have to survive. So some will die, others will survive. And then those that survive will multiply and become the predominant ones, resistant. So we shouldn't use antibiotics in the first place. Okay, and how do we ensure that we don't use antibiotics in the first place? It's ensuring that we do not get infections, because the reason why we use them is because we get infections. So, and how do we prevent infections? Infection prevention and control, standard precautions. We should observe standard precautions. We should ensure that we wash our hands. Okay, we have a clean environment. Okay, we dispose of our waste very well, whether human waste or any other waste should be disposed of well. Okay, and then of course, injection safety in the hospitals and other measures. Also, what we call transmission-based precautions, because you want to break the chain of transmission. How do these, bacteria, how are infections transmitted? Okay, you need to know, is it contact? If it is contact, how do you make sure that you apply the right contact precautions to prevent the transmission? Washing hands is the best contact precaution ever. Just wash hands, because when you touch the desk, you pick bacteria. You don't know whether they are resistant or not. But when you wash your hands, you're going to remove those bacteria, and so you're going to break the chain of transmission to yourself or to any other person that you're going to touch. Okay? If it's airborne, okay, put on a mask and other measures. Okay? Droplet, still the same thing. So in other words, infection prevention is very key. The other important thing is education. So we need to educate people, like now what you're doing here. You want to put this out, and then people are going to get some insight into this AMR problem. This is very key. So we need to educate the public, we need to educate the healthcare workers, we need to educate the patients, we need to educate everyone about this AMR problem. Yeah. Okay. The other thing is we need to do surveillance, we need to do intelligence. Okay, we need to spy on these organisms so that we know the resistance that they are developing. What is the trend? How far have they gone in terms of the resistance? You understand? What is the impact? So that's surveillance, all right? Because you cannot fight something that you have no intelligence about, that you are not spying on. You understand? So that's when now the WHO comes in its resolution 68.7, WHA, the World Health Assembly, through its resolution 68.7, established the Global Antimicrobial Surveillance System, WHO, GLASS, what we call GLASS. Okay? And WHO is saying that every country should ensure that they do surveillance on AMR. There should be a national coordinating center, okay, which we are happy to have in our country at the ministry. Okay? We have an AMR subcommittee. There should be a national reference lab, which we have in Butabika. Okay, and then we should have sites, clinical sites, hospitals, where we're going to get samples and do which we have. The question is, where is the data? There's no data. So what is happening? We have all those infrastructure, but there's no data. What happened? We should ask ourselves those questions. So those are basically the prevention measures that we do. Of course, and others, like for example, in agriculture, ensuring that we stop misusing antibiotics in agriculture. we should put restrictions on access, over-the-counter access to the antibiotics, okay? So that not everyone can get the antibiotics. Prescribers, we should limit the prescribers. We should say, okay, this is the group that's supposed to prescribe. But as we see, as how the things stand, the situation, everyone, for example, in Uganda here, everyone can prescribe an antibiotic, right from the herbalist, the witch doctor, everyone can prescribe an antibiotic, okay? Which is not supposed to be. So we need to really be. And then above all, we need to do mindset change.
Okay, so when you talked about the prescribing, you got me thinking. I think one of the biggest problems we have right now in Uganda is self-prescription. Like, we have very many pharmacies coming up, which could be a good thing, but also a bad thing. So when someone gets like a cough, they run and get an antibiotic. So maybe you could talk to the viewers about self-prescription, its danger in relation to antimicrobial resistance. Yeah, and at least the importance of going to hospital and finding the right diagnosis. Yeah.
Yeah, so self-prescription is a bad habit, and it has actually, it's one of the leading escalators of AMR, okay? So the problem with that is that you cannot know whether you have an infectious disease or not, you as a patient, okay, as a layman, okay? And so when you go ahead and prescribe yourself an antibiotic, first of all, you don't know the right dosage, you don't know the right frequency, okay? So duration, frequency, and you don't even know what you're targeting, okay? Because not every antibiotic will deal with any infection, okay? So in other words, you're basically doing a serious disservice by first of all abusing the antibiotic, and then in the long run you develop resistance because you're going to use the antibiotic inappropriately through the self-medication. That resistance that develops in you does not stop at you, okay? It is going to continue to your friends, to your neighbors, to your children. Why? Because these bacteria that I told you already that are in our bodies, okay, are going to get resistant to these antibiotics that you're self-medicating yourself with, okay? When you go to the toilet, you're going to deposit those bacteria there. Someone else is going to come and use the toilet and going to pick those bacteria from the toilet seat, okay? And then probably they don't wash their hands or they do what, and then they take them in. They become part of their what? So because basically these bacteria spread through contact. So you who has developed resistance to these organisms, so to these antibiotics, you're going to put these bacteria everywhere, and people are going to get in contact with them, including your family members, and so you're going to just escalate the whole problem in the community.
So we have come to the end of the episode. So I would want you to maybe give some closing remarks to the public in regards to the topic. What's your advice?
What is important is for the public to be aware of this problem, that for the 80 years that we've used these antibiotics, we've misused them. And before the antibiotics, we started using these antibiotics, we're not able to do certain practices, certain interventions in medicine. For example, we're not able to do chemotherapy because we knew chemotherapy suppresses the immunity and people are at risk of infections. But because we have antibiotics, we can deal with that. We couldn't do invasive surgery because then we are going to put the patient at risk of infection, but because we have antibiotics, we can deal with that. Care for prematures, dialysis, ICU, we couldn't do all those procedures that require instrumentation because we didn't have antibiotics. But when we got the antibiotics, medicine was modernized, okay? But now that we have this problem of AMR, we are going to go back to a situation where we cannot do those interventions, where ICUs will close, cancer chemotherapies will close, dialysis will close, everything will close. So it is important that the public is aware of this danger and the individual responsibility that is required by all of us to ensure that we do not escalate this problem.
Thank you so much, Dr. Simon, for coming and teaching us about antimicrobial resistance. I'm sure our viewers have learned a lot. I've personally learned a lot. I'm sure we're going to reduce on self-prescription. That's a danger, like we have seen. We've seen the individual responsibility that you have to stop antimicrobial resistance, or at least reduce it. I'm sure the public has known how we can reduce it in agriculture, what we can do to reduce it, basically. So yeah, thank you for watching. You can feel free to comment in the comment section any questions you have or any topic you'd want us to cover on this platform here. Thank you so much for watching. This is the My Doctor podcast. Stay with us.
My Doctor, your health anytime, anywhere.